Hello, my name is Martha Tesfalul, and I'm an MFM Fellow at the University of California, San Francisco. I am also fortunate to have received the SMFM Queenan Global Health Fellowship last year, although the reason for the asterisk next to 2020 will become more apparent during my presentation. I would like to thank Dr. Elizabeth Stringer and the SMFM Global Health Committee for providing me with the opportunity to share about my proposed work to enhance perinatal outcomes in Eritrea through what my collaborators and I are calling the SELAM Study. I have no disclosures. My hope is that after this presentation, you will be able to describe the assets and needs around labor management and related opportunities to improve neonatal outcomes in 𝗪𝗪𝗰𝗴, Eritrea, and also that you will be able to identify the challenges of engaging in global health work in the context of the COVID-19 pandemic, as well as other world events. I would like to start by sharing a bit about myself and my long-standing connection to and interest in global health. I am the eldest of 5 children born to Eritrean immigrants who entered the United States during the Eritrean War for Independence. As a child and now as an adult, being Eritrean American has been a critical part of my identity and has allowed me to appreciate the interconnectedness of people despite geographic distance. While I had done work with refugees and immigrants in the United States beforehand, Eritrea was the first place to which I went in seeking engagement in global health work. Alongside an adjunct professor of the country's sole medical school, Oreta, I undertook a self-designed study focused on mental health issues during the summer after graduating from college. Though Eritrea was the youngest African nation during that summer, it would soon give up that title to South Sudan, which was the second place to which I went abroad, this time to engage in medical education. I would then go on to take a year out between my 3rd and 4th year of medical school to do a Doris Duke International Clinical Research Fellowship in Botswana, focused on the use of telemedicine to support the healthcare system. More recently, during my residency, I was able to engage in both clinical care and to support research in Uganda. I have been encouraged by every single one of these and other shorter endeavors I have taken to continue to seek out collaboration on global health work. And I'm excited to have the opportunity to, in essence, go back to where it all started through engaging in investigator-initiated research in Eritrea with the Queenan Global Health Fellowship. Eritrea is located in the Horn of Africa, bordered by Djibouti, Ethiopia, Sudan, and the Red Sea. It achieved its independence after a 30-year-long war that ended in 1991, and its population has essentially doubled since that time to approximately 6.5 million people. The large coastal line is an invaluable resource to the country, but the climate there is quite hot and dry, so the majority of the people of Eritrea live in the inlands where the temperature is more temperate and the land more fertile and green. According to the World Bank, almost 2/3 of the population lives in rural settings, and a similar proportion make their living in agriculture. Since gaining its independence, the government has prioritized health and education, as evidenced by the fact that it's one of the few countries that was able to meet all 3 health-related Millennium Development Goals by 2015. While all of my immediate family and a number of my relatives are in the Eritrean diaspora, the majority of my extended family is in Eritrea. These are a small subset of the countless photographs I have that capture just a glimpse into what I love so much about Eritrea: the incredible people, the strong sense of community, and the unwavering resilience. In early 2019, I was introduced to Hannah Emanuel, pictured on the left, and later her uncle, Dr. 𝗘𝗿𝗄. They are the co-founders of a nonprofit called 𝗲𝗏𝗰𝗴, which means Freedom from Hardship in Tigrinya, one of Eritrea's 9 national languages. 𝗲𝗏𝗏 trains and mobilizes female health workers in rural Eritrea to support women in their own communities and collaborated closely with a highly reputable Catholic clinical partner. Through our discussions, we realized that there was potential for synergy of my professional interest and their desires to enhance 𝗲𝗏𝗏's work. We thus worked together along with my MFM Fellowship Director and dear mentor, Dr. 𝗬𝗲𝗂𝗪 to prepare a proposal for the SMFM Queenan Global Health Fellowship seed funding. In it, we outlined a plan to engage with key stakeholders on how to make the healthcare workers' training and efforts more responsive to local drivers of maternal and neonatal morbidity and mortality, as well as more responsive to community-identified needs. While fortunate to have our proposal approved, in the summer of 2019, the Eritrean government assumed control of all Catholic-run hospitals and clinical sites, and various downstream changes resulted in the pause of RAHWA's activities and thus a need for me to reconsider if there was still a way to further the mission of the SMFM Queenan Global Health Fellowship with a different project. While we were all, of course, disappointed, Dr. 𝗖𝗍cie HS𝗲𝗲, who is now an MD PhD student at Harvard Medical School, and I put our heads together to determine if there might still be a way to leverage the seed funding that had been allocated to our initial project to advance obstetric care in Eritrea in another way. With their help, I was able to connect with other in-country providers and planned a self-funded trip to Eritrea in December of 2019 into January of 2020 to determine what might be possible. Fortunately, that trip allowed me to return with a very different but nonetheless exciting proposal, this time focused on hospital-based care at 𝗦𝗘𝗟𝗏 Referral Hospital. For context, Eritrea is split into 6 regions, known as zobas, each with its own capital and its own regional referral hospital. 𝗦𝗘𝗟𝗏 is the capital of the southern, or 𝗕𝗲𝗴𝗏 region, which is the most populated of all the zobas with an estimated catchment of 1.5 million people. At the 𝗦𝗘𝗟𝗏 Referral Hospital, I was connected to and had the opportunity to spend time with Dr. 𝗕𝗿𝗏, who is one of the lead OB-GYNs, and Dr. Samson Abai, who is the lead pediatrician. The 3 of us are pictured in a doorway of one of the hospital wards, in the picture at the bottom, and I've also included at the top a photo that was taken in 2009, 10 years earlier, of Dr. Samson and I, when he was a pediatric resident in Asmara and I was in Eritrea engaging in mental health research as well as shadowing opportunities at Orita Medical School. It became immediately clear that both Drs. 𝗬𝗏 and Samson would be incredible collaborators, particularly since both have a strong interest in research. In our conversations, both Drs. 𝗬𝗏 and Samson expressed a desire to focus on perinatal deaths, noting that targeted efforts focused on maternal deaths had realized significant reductions throughout the country, and thus they were hopeful that the needle could also be moved for stillbirths and early neonatal deaths. Given that there was more data and emphasis on the latter already, we decided first to delve into the challenge of stillbirths. As quick background, the majority of the estimated 7,000 stillbirths that occur daily happen in low-resource settings, and it's estimated that 50% occur during the labor and delivery process. While these numbers are tragic, there is hope in that the majority of these stillbirths are thought to be preventable. But unlike neonatal and early childhood deaths, stillbirths are often, as the WHO notes in this graphic, a neglected tragedy. In order to understand where to best focus our efforts, we reviewed all of the 2019 birth registry data, kept on bound paper logs, data on different factors including maternal age, parity, select antenatal issues, mode of delivery, birth weight, and initial neonatal status, including whether they were living or stillborn, were captured on every single delivery. Notably, no neonatal death data was captured in the birth registries, though they were documented on the pediatric side. Of the slightly more than 2,000 deliveries done in 2019, there were 78 stillbirths captured, and of those with available paper charts, 50% had a fetal heart rate on admission, whereas 50% were diagnosed with an intrauterine fetal demise upon presentation, similar to estimates in the literature. Given that such a large proportion were occurring during admission, Drs. 𝗬𝗏, Samson, and I agreed that focusing on this issue was important and elected to go further to determine which patients were at highest risk. We thus did a simple case control analysis of singleton, non-anomalous stillbirth admissions as the cases and the admissions of patients that were discharged immediately before and after as controls. We then calculated the odds ratio for stillbirth for each of the available variables using STATA. Given the small numbers, we abstained from doing multivariate analyses. We found a number of variables were significantly associated with higher odds of stillbirth. Among maternal factors, maternal age greater than or equal to 35 at the time of delivery was associated with an odds ratio of 3.2 and grand multiparity with an odds ratio of 3.0. Among obstetric factors, odds ratio for stillbirth with abruption was 8.4, and while 12 of the stillbirths occurred in the context of uterine rupture, there were no uterine ruptures among the controls. Low birth weight was associated with a 4 times greater odds of stillbirth. And while the p-value for night shift delivery was 0.05, it was interesting to note the higher proportion of stillbirths occurring at night when compared to controls. Nulliparity, preeclampsia, hemorrhage, obstructed labor, malpresentation, and mode of delivery were not statistically associated with stillbirth in this small cohort. After reviewing the preceding data, Drs. 𝗣𝗿, Sampson, and I engaged in discussions on how to lower the frequency of perinatal deaths. While not formally done in this way, I have elected to represent the key points of our deliberation using the framework of SWOT Analysis, which stands for Strengths, Weaknesses, Opportunities, and Threats. With regards to strengths, a major one is the dedication of the providers in both the pediatric and obstetric wards. This includes not only the physicians, but also midwives, nurses, and staff who were very engaged in doing work that is not traditionally assigned to their respective roles in an effort to optimize patient outcomes. In Eritrea, in contrast to some other care settings, there is limited direct cost to patients for accessing care, which is another strength. Additionally, the Eritrean Ministry of Health has had a long-standing and strong commitment to maternal and child health, both in terms of priorities and resources. Weaknesses that we discussed included the clinical demand that exists, particularly on Drs. 𝗣𝗿 and Sampson, given their leadership roles at the hospital. We also discussed that while overall well-stocked, there is an acknowledgement of intermittent challenges with supplies, as well as the quality of equipment that is available, even though it is functional. In addition, when reviewing charts, documentation of things like partograph use was inconsistent, and in conversations with providers on the labor floor, it seemed that there was variation in day-to-day practices and care of patients. With regards to opportunities, the long-standing commitment to serve in 𝗪𝗪𝗏 that both Drs. 𝗣𝗿 and Sampson have are invaluable and provide an opportunity both to leverage their institutional memory and influence, as well as to be responsive to what they, from their experience, know to be critical in the care of patients in that region. The rotating providers that come to 𝗪𝗪𝗏 for various training, including in cesarean section, also present an opportunity for training them in various skills and initiatives to decrease perinatal deaths could present an opportunity for them to take that work to their primary sites. Finally, the fact that the Ministry of Health has made significant progress towards its existing targets invites the opportunity to create new, more ambitious targets around challenges such as perinatal loss. Unfortunately, the threats in 2020 were quite significant. While we did not know it at the time, when I was in Eritrea in December of 2019 into January of 2020, the COVID pandemic was blooming in the air. We did, however, recognize that Drs. 𝗣𝗿 and Sampson's demanding clinical schedules would present a challenge, as well as their limited access to internet, which was only once every 1 to 2 weeks, prior to the pandemic and became even more and more sparse. Nonetheless, in spite of these threats, we were very motivated to do what we could to address the challenge of perinatal deaths. And ultimately, we decided that addressing one of the weaknesses that we thought could make the most impact would be ideal. That weakness was the variable care management of patients in labor. We thus came together to design what we are calling the SELAM Study, which stands for Strengthening Eritrean Labor Assessment and Management. In Tigrinya, SELAM can be used as a greeting and also means peace. We all agree that the acronym was quite fitting, as our hope is that this work will allow for more peaceful beginnings for those born at 𝗦𝗘𝗏𝗰𝗴 Referral Hospital. For the SELAM study, we're proposing 3 primary activities. The first is to optimize our understanding of the factors impacting perinatal survival at 𝗦𝗘𝗏𝗃 Referral Hospital by optimizing the systems for data capture and analysis. While it was impressive to realize that there were upwards of 5 years of delivery charts available on site, the reality that the data was on paper and had limited organization presented a major barrier to being able to act on the information within it. We thus want to develop a system to initiate an electronic delivery database to complement the required paper documentation that exists. The goal would be for select deliveries, particularly those with adverse outcomes, to be captured along with variables that are important but not routinely captured in the existing registry logs, factors such as partograph use and neonatal survival to discharge. Given that both Drs. 𝗣𝗿 and Sampson have an interest and prior experience with data analysis, we will be securing data in order to allow them to analyze data on site. Second, we are proposing activities to develop a tailored labor management protocol for 𝗦𝗘𝗏𝗃 Referral Hospital. Inspired by efforts at other resource-limited settings, we will adapt protocols based on the Ministry of Health guidelines, but specifically seek to address key facilitators and barriers to optimal labor management at the clinical site. Finally, our last group of proposed activities are going to involve implementation of the tailored protocols. We recognize that in order to implement the protocols that are created, there might be a need to potentially procure additional equipment and resources. We also recognize that there is a need not only to track our primary outcome of perinatal losses, but also process metrics such as partograph use and time between last documented fetal heart rate and delivery, as well as balancing measures such as maternal morbidity or mortality to ensure that the increased focus on neonates does not have unintentional harms for mothers. Similar work done adapting guidelines to local context in the 𝗕𝗏𝗄 study in Tanzania decreased rates of stillbirths by 1/3 and improved APGARs for live-born neonates. We are eager to learn if we can realize similar, if not greater, impacts in the context of 𝗦𝗘𝗏𝗃. This donut illustrates the proposed breakdown for the use of the $15,000 of seed funding provided through the Queenan Global Health Fellowship. Given the recognition that a lot of the proposed work will need to be facilitated on site and that my collaborators in 𝗦𝗘𝗏𝗃 have very heavy workloads, the largest portion of the budget was anticipated to go to travel so that I could be present and lead key steps of the execution of the SELAM study. We also had hoped to augment the capacity to further the study while I'm not on the ground through the engagement of a local research assistant. As noted on the previous slide, we also anticipated that locally tailoring guidelines might reveal local resource needs, so we budgeted funds in order to be able to purchase equipment and supplies if needed. Fortunately, the proposal to undertake the SELAM study was approved, but unfortunately, 2020 presented unprecedented challenges. The most significant of the challenges faced was, of course, the COVID-19 pandemic. This slide illustrates the original timeline for our proposed work. As mentioned before, I traveled to Eritrea in December of 2019, returning in January of 2020 with the plan for the SELAM Study. My collaborators and I had already reached out to the Ministry of Health in Eritrea prior to my leaving the country, and were hopeful that once the study proposal was submitted that we would hear a response within 2 months. I worked with my UCSF faculty and co-fellows to outline a rotation schedule that would provide me with the flexibility to travel back 1 to 2 times early on after getting approval to start collecting data on tailoring labor management guidelines and to aid in the tailored guidelines implementation. The plan was to allow for 2 to 3 months of a run-in period with the new guidelines or protocols, and then to start collecting data in the fall of 2020, which we would then analyze and present in the spring of 2021. And then ultimately, my hope is to secure an MFM faculty position in the fall of 2021 that would allow me to continue to collaborate with the providers in Mandevra. This, however, is the actual timeline in which my collaborators and I find ourselves. The red bars indicate factors that have caused significant delays throughout the whole process, most notably COVID-19 related travel restrictions and connectivity issues that have greatly impacted individuals in Eritrea. In addition to the 2019 related setbacks, I want to highlight that near the end of 2020, there were issues in the Horn of Africa, raising questions about regional stability that also could have an impact on the study feasibility. Given all of the setbacks noted here, I requested an extension for use of the Queenan seed funding until the end of this year, which has fortunately been granted. At the time of last year's SMFM conference, I was incredibly excited about all that I was hoping to accomplish with the support of the funds from the generous Foundation for SMFM, and envisioned this presentation as being full of much greater progress. As I'm sure is true for many of you, the blows of 2020 and even early 2021 have at times felt like too much to get past. But the hopefulness and encouragement for patients from Drs. 𝗣𝗿 and Sampson in our infrequent but always heartening communications have taught me firsthand the importance of resilience, and we will therefore continue to press on. Currently, Drs. 𝗣𝗿, Sampson, and I are in the process of working with the Eritrean Ministry of Health to determine exactly how the seed funds will be spent in country. My hope is that I will be able to travel to Eritrea at some point in the near future, particularly in light of the increased dissemination of the COVID-19 vaccines. Despite the delays, the need for engaging in this work persists, and thus I am eager to do what I can when I can. In closing, I would like to thank again Dr. Stringer and the SMFM Global Health Committee for providing me with this opportunity to share an update on the progress towards the realization of my Queenan Global Health Fellowship project. I would also like to sincerely thank the Foundation for SMFM, including Michelle Prince and Lolita Hampton, Dr. Vincenzo Bergella, and the Queenan Fellowship Selection Committee for funding my initial proposal, for choosing to maintain that funding when I had to revise my proposal, but most importantly for encouraging me to continue in this work despite the many setbacks that I faced. I would also like to thank the following individuals who I mentioned at various points during this presentation: Dr. Juan Gonzalez Velez, future Dr. Hannah Emanuel, and Dr. Kibram Tsagay, Dr. Samson Abai, and Dr. Dawit Wildet Gabriel. I would also like to thank Mr. Yamane Gabrab and Ms. Hadanet Kaleta for their support in opening of doors while I made that initial trip back in December of 2019. And last but definitely not least, I would like to thank my family and friends in Eritrea who have provided me with invaluable support around this project and countless other endeavors in my life. I would not be doing this work without their support. And of course, thank you for taking the time out of your day to listen to my presentation. I wholeheartedly welcome any ideas, suggestions, or concerns that any of you listening in might have for the work that I have shared here. Please feel free to reach out to me by email at martha.tesfalul@ucsf.edu. That's martha.tesfalul@ucsf.edu. I would love to hear from you, and again, appreciate you for taking the time out of your day to listen.